when people go and buy a car, they're gonna test drive like I don't know what, right? When you're getting a new doctor, you're getting a new doctor. Most people will just simply whoever you gave me. Like, come on. I mean, this is your health is more important than the car you drive. I mean, I honestly think that when your doctor retires, right, and you want to find someone, you probably should have like a half a dozen of discovery calls before you decide to settle on someone.
See, I have a problem. The doctor I was working with for a decade retired, and my insurance requires me to have a primary care physician. Of course, the clinic had somebody lined up, but healthcare in this country is already not very good, to say it mildly. And to jump on the first opportunity blindly would be totally crazy. It's not how you live to be 100 years old or more by design. So I had to urgently educate myself about healthcare system and how to find the best doctor. And because I like to do things systematically and in a repeatable manner, I have created this list of discovery questions you have to ask your PCP if you want somebody good. So they go in the specific order because how conversation should flow more naturally. But what I'm going to do now is to actually test them on the real doctor and get some immediate feedback and hopefully some insights into the system. And we'll see how it goes. I do it for myself mostly and my friends, so let's get started. And so we start our discovery call, and can you introduce yourself? If you're going to be my doctor, it will be mostly me talking, right? So I want to level the field a little bit.
The regular doctor would say something like this. I'm Dr. Kogan, that's me. Mm-hmm. Nice to meet you, Alex. So I'm an internist, but I'm also certified in palliative care and geriatrics. And I've also done significant training in integrative medicine. I even served on the first board of American Board of Integrative Medicine. And so I've been in practice for over 20 years. Usually that's about where people will stop. Mm-hmm. Now, what I do in my practice, though, is dramatically different from sort of the regular care, because somewhere earlier in my medical school, I start realizing that I don't want to practice standard of care. I don't like the way the medicine is basically dramatically geared toward pharmaceutical and procedures, that the prevention, lifestyle, natural medicines are afterthought and not the first thought. And I said to myself, I don't want to do that. I want that to be the first line of treatment. So but I also always been an academically inclined. I like research. I like teaching, although most of what I do, 80% of what I do is clinical and administrative, as I kind of operate my own clinic.
But you started in geriatrics.
Well, I started in internal medicine. So like the way this works is that I first did a training in internal medicine before I then took a specialty fellowship in geriatrics, right? And then a little bit later, I also got certified in palliative. Interestingly, I never did a formal training in integrative medicine. As of about 15 years now, the integrative medicine is now its own standard pathway. So it's just like you would have to take a fellowship training after your residency to go and become an integrative medicine certified physician. So that's one way you can think about finding a doctor. You can find a doctor who's certified in integrative medicine. I didn't do a formal training because when I was in training, there was no formal training. So I ended up kind of just learning it all on my own.
What's your main interest today? Let's put it this way.
Well, so my main interest today is to take a person who's in their 40s, 50s, and 60s, and who is saying to me, look, I would like to make it to 100 or plus, 100 plus, help me. Like, that's my main interest. Mm-hmm. I also have a very specific interest in cognitive health. And so we have a program called RECODE. It's a Dale Bredesen program where we have about 80% success of reversing cognitive decline, and we can talk about that if we have time. Mm-hmm. So that's my second kind of big interest.
And what do you do to stay current with all the research?
That's great question. So first of all, we have a big team of 20 people. So we weekly meet and we bring up, like today, we're going to talk about this brand new article that just came out a couple of days ago in New England in British Medical Journal, saying that 750,000 Americans die everywhere from incorrect care. That basically wrong diagnosis, not enough time to establish diagnosis, not having enough skills to assess properly, and that kills a lot of people. So we do journal clubs every month, roughly. So we learn the most important critical. And then I'm also an associate professor of medicine full-time at university, where I have to take a lot of CME credits every week. We have to do grand rounds. I teach. So I actually find myself the best way I learn is when I need to prepare a talk. Because the quality of what you're presenting needs to be higher than what you need to learn yourself. That's been my motto in academia. So I probably give lecture on average two or three times a month.
So yeah, it looks like you're busy. So
I'm busy. I like it that way.
Yeah, I also like to be busy. But when it comes to patients, how much time then do you spend with a patient when you have such a busy schedule?
Well, so actually, I see patients clinically roughly 2.5 days a week. So I actually have a lot of protected time because there's a lot to learn. There's a lot to learn. And my visits, if I have an insurance-based practice at university 1 day a week, where my visits are usually an hour for initial and 30 minutes for follow-up. But in my own practice, usually initial is 90 minutes. And then the follow-up somewhere between 30 to 60 minutes, depending on the type of a problem. And about 50% of everything I do is telemedicine, and 50% is in person.
So if I come to your, let's say, that insurance-based practice, are there any other ways to communicate over email or text messages? If I need something simple, like a change of prescription or...
Right. So we have a portal. So, and then there's also a phone line where people will call to kind of get in, if they want to talk to a person. The problem is that this is a large university. If you don't send me the message through a portal, which a lot of my older patients not able to, they just don't use the portals. But if they can't send the message through the portal, then they have to call, and the phone lines are not always easy to sort of get things done through. It's a very large university, so it's not administratively run as good as my private practice, but it's insurance based. So, and so basically the reason I do it this way is that when I'm in university practicing mostly geriatrics, I don't, not only, but 2/3 of all my patients there are people over 65. My practice there is more in line with standard of care. I always talk about prevention. I always talk about integrative modalities. But first and foremost, I'm going to follow a standard guidelines. I'm going to suggest.
You have to. Yeah.
I have to, actually, and that's essential. So I have to. I mean, I will sort of suggest vaccinations, even if somebody's coming to me and they're strongly opposing it, the whole principle of vaccinations. That's their choice, but I have to, by law, suggest that and document that we talked about it. So this is just what the legal system requires. But this is why I don't practice in just one place. So in my private practice, we're 100% out of network. We're 100% out of, because there we don't practice standard of care. It's 100% integrative medicine. It's 100% prevention, but it's expensive. Because of that, if you don't have a Cadillac insurance that will reimburse you for any visit to any provider, then you're probably going to be quite, at least a couple of $1,000s a year. If you're going to see us 3-4 times a year, it's going to be pricey. But a lot of patients feel that that's the value they would like to pay for.
What I'm trying to understand is if I can communicate over the portal, right, sort of to reduce that cost. It's a very simple approach. Is it going to cost me arm and leg if I just email you and say, okay, that brand of vitamins out, I need to change to this. Is it okay?
Right. So that's a great question. So a lot of practices right now, and I know quite really good practices in Boston that do that, where you would pay someone an annual fee to have that unlimited access to the messaging. We do it a bit differently. So in my private practice, we don't charge people for that at all. But if the number of messaging becomes significant, we will simply bill on time. So we will say, look, I spent an hour a month on your chart, so I'm going to bill you for that. If it's one quick question, usually we don't. But there are also some patients in our practice who are also in the concierge because they want to have a kind of premier access. So they would want to get in quickly. They would want to not worry about number of messaging going back and forth. They want to simply call my office and say, I need to talk to Kogan tomorrow at 4:00, and then the call placed back. So they kind of value that relationship. We're pricing this at $1,500 a year, which is kind of probably about an average for most practices. Usually it's somewhere between $100 to $150 a month in our area. In some areas,
yeah, I think it's
more or less
much the same in the Boston area, from what I've seen.
Right, but it's sort of interesting because I was just reading a New England Journal of Medicine article called "Death by Portal." Physician in Philadelphia, in Jefferson, basically got burned out completely because she was spending 2 hours a day answering messages through portal. She felt bad charging for it, and she basically quit.
Well, I mean, you need to find the sort of right balance, I think.
Right, because people often, we find this quite often, and patients would message us minutia that they can figure it out, or it can simply wait till the next visit. But as you pointed out, when certain supplements, for example, are out, like how do you replace that, right? So you need to have a system in place to manage this. Usually, we have direct access to all of us. And then, basically, if the patient is in the concierge, then it's unlimited. If they're not, then we just use our judgment. If it's a one quick question scheduling or something, we'll simply forward it to front desk. If they have a clinical question, we often say, you're not in concierge, so I suggest you make an appointment. But if it's something that I can answer in one little line, that's what I'll do. I think the same way with insurance. So, I would simply respond to a patient through the portal with one line saying, we need to talk or something like that.
What if, let's say, I need a prescription or a blood test?
So the prescriptions are renewed automatically. So now everything's electronic. Both places, we have 100% electronic. So they basically send automatically to the pharmacy to get renewed. So the blood work is a little trickier. Sometimes I would simply order it, but the blood work often requires conversation because it's not usually that easy unless it's something very routine and like, let's say you're monitored for something and then.
Well, I'm monitoring, I can give you an example. This year I've dedicated to figure out my ApoB, heart health, cholesterol. So I did all the readings. I spoke with my doctor who now retired, but I decided to do several basic interventions. Try niacin for a couple months, see what happens. Try a high dose of omega oils for a couple months, see what happens. So I need to do baseline, ApoB blood test, and maybe some inflammation markers. Then I need to repeat it in 2 months. Then I've been taking omega oils for another 2 months. I need another blood test. Is it, and I probably don't need like whole appointment to do that.
So what you're describing is a perfect patient for concierge practice because you're basically saying, look, my needs are not your typical needs when I only going to call you for emergency. My needs are continuous. I have multiple things I want to think about. I value my health to a point where I understand that I don't want to sort of wait till the next appointment. I need to do a whole bunch of stuff. And because it's routine and we don't have to talk, so basically when you enter concierge agreement on your end like this, you telling your doctor, hey, I value your time. And more importantly, I value our relationship. One of the problems people don't realize in US, right, most of the relationships are commercially based or they're professionally based, right? So they should be appropriately set from the boundaries perspective. We often don't realize there's a lot of situations where patients would send some things that are clearly cross the boundary into this is not a professional communication. So when you create the financial agreement with the provider, you're setting that boundary in place from the beginning. You understand the rules of this communication. And within that's when you're going to get the best results. Looking for a practice in your situation, you're looking for a physician who's going to say something like, oh, I'm going to bill you every time you email me. That's probably going to run into lots of trouble for both sides. Because
I'm okay with either way. I just want to know ahead of time what I'm getting into, and I want to
establish proper channel. Exactly.
And everyone can decide if it works or not.
Exactly. My point is that a lot of the times when people think through this, they don't realize that when you create that arrangement, you make it clear for both sides, and it's a path to success.
Yeah. I always say that it's better to know what's going on than to be in the state of unknown, because it's just more stressful for everyone.
Exactly. The classic path to failure, which actually for some reason a lot of our Russian friends follow, is this. They find a good doctor somewhere in academia, like in a large university, because somebody said, oh, this is the best physician for this. But they don't realize that for the doctor may be genius and wonderful, but if the infrastructure is not set in place right for what you need, it's a total disaster. This is when things fail, because you're going to try to reach your doctor, not because they don't want to, but because the system not in there. You're not going to be able to do that. Or if the system is in place, but the doctor is a researcher, educator, and they're only in clinic 1 day a week, and there's just no way for them to communicate with you frequent enough, you're going to be constantly frustrated. So you really need to look for a practice that, A, you're happy with the person who's in charge of your care in essence, and B, that you're happy with infrastructure. And that's, believe it or not, that second aspect is almost as important as the first one, because quite often, especially in the current healthcare system, a lot of infrastructures are just not designed. They designed for medical emergencies. They're not designed for preventive care.
That's what I always tell my friends who not in the States. I said medical system here is great for emergencies.
Exactly.
But everything else, nope.
Nope.
So let's continue with me. I started to talk about my APOB adventure, but I want to hear your angle also. What do you do for preventing heart disease, cancer, dementia?
Well, so the one thing with us is that we're the personalized medicine is for us already past point. So we're already beyond personalized medicine. So we're in the area where we're combining personalized medicine with functional medicine, which is meaning the following. I will first understand your personal risk factors, which usually involves comprehensive genetic assessment, which usually involves assessment of pretty much of every of your system. And we don't do that by just getting a basic blood work. We do a lot of functional tests where I would look at a particular organ, let's say digestive tract. And I would say, well, your imaging may be perfectly fine, but your bacteria is off, your digestive enzymes are low, and you're not processing your fats well because they're coming out in the stool. So we would look at this from not diagnostic perspective, but from how is your
overall
organ
functional.
operates. Yeah. So, and then within that, once we identify your weak links, that's what we're going to concentrate on. We're not just going to say, oh, your ApoB is elevated, and so it's an inflammatory response.
Why?
Let's go. But why? And that why could be not necessarily have anything to do with your genetics. You could have some toxin hidden somewhere, and that causes an inflammatory response. Or you may have some particular nutritional deficiency, which your certain needs are not met. So like methylation is a very common problem. About 40% of Americans, of course, you know about that, but a lot of people don't. And so we would test for that, and we would say, oh, okay, so you have genetic reason in this case to not methylate some of the enzymes very well. So you need some methylation support to get specific detox and specific processes in better place. So that's the way we think. We don't think in terms of particular problem. We think about why is that problem there. So this is the core difference between integrative medicine and the standard Western model, because Western model treats diagnosis, and it doesn't go beyond that. It simply says, okay, you have lupus. Well, here's here's the immune suppressant for your lupus. We don't stop there. We say, okay, well, but why is this person developed the lupus?
So is there any chance for people who go to a regular doctor to get any of that, would you say?
Highly unlikely. And the reason has nothing to do with what this doctor wants.
Just there is no way to diagnose and put a code on it?
Exactly. This doctor is limited by the setup. If they take insurance, by default, it means that they will have to follow the standard recommendation, or what's called a guidelines. So each disease has a guidelines on how to manage it. Let me give you a very simple example: diabetes. in the diabetes, there is a lip service. Yeah, there's a lip service for lifestyle. It's all, okay, so your number is this, you're going to give this drug. Your number is that, you're going to give that drug. This is how it's practiced. Nobody thinks about something like, okay, let's just pause for a second. Why does this patient have diabetes? What are this person's, and often you, within that thinking, one of my first cases in my practice was a man in his 30s who was diagnosed with type 1, not type 2. And, he was said, okay, here's your insulin for the rest of your life. And when I first saw him, I'm like, this doesn't make sense, right? So what we did is we did a very comprehensive toxicity workup. The guy was a painter and he had a horrendous paint toxicity.
Okay.
We detoxed, he stopped using it. Diabetes went away completely. Off insulin, total normal life 3 years later. So you have to think of the deeper. You can't stop at the way the medicine dictates us how we practice. And you, as a patient, need to be in charge of this. And so your doctor has to, at the very minimum, agree with what I just said. They may not know it. You may help them to teach them. If you're limited on your resources and you can't get into concierge and you have to use insurance, but at least the doctor has to be open to you saying these things.
Oh, yeah.
They have to, and they have to be reachable.
Yes.
Right? For your questions.
Systems, yes.
Yeah, exactly.
So what do you do about cancer with all that approach?
Well, so we have a very complex, very large cancer program kind of in conjunction with some of the things at the GW at George Washington University, breast cancer. We have a lot of parallel. We actually do some mindfulness workshops for the breast cancer and other things, research program.
But general prevention.
Prevention, right. So the general prevention is a bit, again, same principles.
Or early detection, because with cancer, early detection probably as valuable.
Right. So actually, we get more of a patients on the other end, so which they're kind of failing the treatment, or they want some other integrative approaches like intravenous vitamin C for cancer, for example. So they'll come to us. But in cancer prevention generally, it's a lot more complicated topic. Of course, we'll do the same standard screening like every other office will do, but we also will look into kind of this more of a biochemistry and say, okay, your sugar is high. I mean, and you may be not diabetic, but you're pre-diabetic, and that's bad enough to increase risk of cancer. So we will work on that. So often also our ranges for specific things are a bit different.
That is optimal, and optimal is not always.
Let me ask you a question. let me interview you, because when you're doing this interview, by the way, it's just as important that your doctor interviews you too. I'm going to ask you a question. What is your homocysteine?
It's about 7.5.
So we would click really well because I say, perfect, you're under 9, you're at the target. But if you go to a regular physician, and first of all, they'll never ask you this. Second of all, if you ask them what is your optimal homocysteine level, they're probably going to say, well, whatever the lab tells me.
Between 5 and 10 or whatever. And I'm like, no.
No, the normal lab, the normal lab is going to say 15 to 20.
15. Okay.
Yeah, or like 14 to 20. Screw that. It's exactly right. That's like, okay, I'm not looking for disease state here. I know that homocysteine over 10 is a problem. So everybody should be probably under 9, or at least between 9 and 10 if possible, but definitely not over 10.
Yeah, I just saw, a big study that, again, it's more for dementia, but if your homocysteine is higher than, 8 or 9, your chances of dementia are 20% higher.
That's exactly right.
Like,
but you'll ask, but most doctors have no idea about that. And the good news is the treatment for this is very easy.
Very simple, just get methylated vitamins.
Yeah. Or you also can actually do certain foods. If you don't want to take supplements, you actually can. Cara Fitzgerald has a very good book. That book describes very well as to exactly how to achieve it with diet alone. I usually recommend vitamins just because it's much easier. It's usually you take a couple of capsules of methylated B vitamins, and it works more predictable than the diet in my experience.
In my case, I have it MTHFR, so I kind of have to pound on it heavily. But with cancer, do we do something advanced like liquid biopsies or some extra MRI scanning?
So great question. I'm going to give you an answer you may not like, So for example, I strongly discourage people from doing imaging. And here's why. First of all, the quality of current images detecting an actual cancer is poor. You're going to have a lot more schmutzes, what we call them, on the images, which is an iatrogenic.
Of course.
You're going to find things that are not cancer. You're going to find things, and you're going to go and you're going to have to work it up. And this is where you're going to get a biopsy. They may find some atypical cells. And this is where, remember that I told you 750,000 Americans die every year from wrong diagnosis. About 10% of these patients die because of the wrong diagnosis of cancer. They are told they have a cancer and they don't. I actually have a very famous case in my practice where a patient was told he has a pancreatic cancer while it was a benign tumor. It was a very small, they basically took his entire, it's called Whipple procedure. They took the part of there's a massive procedure.
Yeah, but there's always a risk.
There's a risk. They find something on imaging and then they're going to, so I'm very skeptical. Basically, the way I think of it, we look at this a little different. First of all, we look at the kind of a biochemical risk first. Then we add blood work. Whether, we like liquid biopsies. We also like some specific markers of inflammation. Things like, the certain things people never heard of, like VGF, for example.
Yep.
We like IL-6. We like certain things that are showing me if those are elevated, it's an atypical inflammatory response. It could signal the cancer. Then we would proceed to something like a liquid biopsy or whatever, like some other. Or not just liquid biopsy. We could also look for a cancer cells, progenitor cancer cells, or cancer stem cells in the blood. That's also a very effective test. And if you find them, then you're really concerned and you need to treat the whole body rather than just take a chemotherapy and radiation to specific organ. So there are more newer methods like this, and often they're kind of on the fringe. A lot of oncologists will not do these tests because they're often not covered by insurances. Some of these tests are very expensive, like some of the liquid biopsies are way over $1,000 each and never covered. So, you're looking at some of the sort of associated costs here, and common oncology practices, if they're 100% insurance, they will not include anything that's out of pocket, regardless of the evidence. That's just the way systems set up. So if you're going to go to your oncologist or your internist who works with an oncology practice in the same group, and you're going to say, I would like that, they're probably going to say no, not because they may 100% not support it, but because they don't have a system to order the test. So they will tell you, well, good luck, go find it somewhere else. And they won't have a system. They wouldn't want to set up a system how to get this because it's an extra work for nothing. So remember, medicine is business. Well, for you and I, there's one MRI that probably going to be very relevant in some 10, 20 years, which is the prostate MRI.
Prostate, yep. Yeah.
That's one MRI
not
that
everyone dies from prostate cancer, but everyone male dies with a prostate cancer.
That's exactly right. That's 100% accurate statement. And because of that, it maybe makes sense to get an MRI at some point to say...
Just to see what's your baseline and how does it changes.
That's right.
Yeah,
right.
Because not everything has to be treated, but you need to be aware of...
Or the treatment doesn't... I published a couple of years ago a case. We had a gentleman who came to us with rapidly rising PSA, early cancer on the biopsy, MRI clearly showing the cancer was limited to the prostate. It didn't spread yet. And so he said, I'm not going to take any standard care. And actually, nobody offered him much because his Gleason score, which is the severity of kind of pathology of the cancer, was pretty low. It was 6. So his urologist said, we're just going to monitor you. And when he asked, what does that mean? They said, oh, we're just going to check your PSA every 6 months, but you don't have to do anything, eat whatever you want. He's like, whoa. So he came to me and we created a very interesting complex protocol. I can send you an article if you're interested. And part of that protocol he found on his own to use cannabis. So we actually use rectal cannabis as part of his treatment, and he's got cured. In a year, there is no cancer anymore. Just went away. They repeat the biopsy, and there was no cancer. So we published this case because it shows you that often, if you have time and you can safely implement some of the cancer treatments that are completely natural.
You can definitely try them and see.
You can try them. You have no risk, right? Exactly. Because if they're not doing anything, then why not? Like the other cancer, which is very common, relatively speaking, it's called chronic lymphocytic leukemia, or CLL, which is I often get patients call me because I also had some success in treating this particular cancer. So you just kind of explain to them and say, look, this is what we're going to try, and if it works, great, and if it's not, when your oncologist tells you it's time to do whatever, then you'll
just go with that. And it doesn't mean that you cannot combine several treatments.
Because that's the integrative medicine.
Yeah, because somehow a lot of people I see, they like to go to camps. We only do standard or we only do natural. Like, try both.
Right. Exactly. So that's actually a really important point. People who tend to do only one direction, they're missing out.
Oh, yeah.
I would say people who just do alternative missing out more, because when they're going to get an emergency of some sort and they're going to refuse a standard of care, they're going to be in a major risk. Although, you want to hear the funny part? I'm yet to see a single person when they actually have an accident, like a car accident, or they fell on the skis and they broke their leg. They will refuse the standard of care. So they will say, "Oh, I'm all natural," but then the accident happens and they'll be just as happy to go to you. Give me morphine, exactly. So I think that there's a it's not black and white. It's all kinds of shades of gray, and the reality also, people's opinion changes and they experience changes, and so quite often people move on that continuum from one spectrum to the other, but the people who are on the right, only standard of care, they're actually missing out a lot too, because often, I just said it, and I will put the link to the study. I mean, this is British Medical Journals, and we all knew about this. Like, I've been advocating for less medicalization of healthcare for a very long time, particularly for people who are over 50. When you're 35, you're simply not entering healthcare system that often. But once you reach a certain age, it's just statistically speaking, the chances of entering healthcare system for all kinds of reasons going to go up.
Yep.
And the problem there is when you enter the system that is highly inefficient, that makes a lot of errors, and that treats everything with a hammer when you may need a feather, it's just not right. And so that's the thing, like finding the provider who will always support your journey and understand your values. Is actually
and limitations and maybe
exactly. And when you're sort of saying something crazy, they're going to redirect you and say, "Nah, let's just and there has to be this trust also, like some bilateral trust, where you need to understand that your provider is always going to be supportive, and they're not going to tell you something because it's simply they make more money or that they're just whatever, right? So that they're always going to have your interest first, regardless of what's happening." And that also could mean tough truth, because there are practices that I know, and I'm not naming anybody, they will simply just follow whatever patients tell, and they say, whatever, and we're just here to make money.
Because
that's also bad.
I want to triangulate.
That's right.
I value my opinion, but I go to professional to get professional opinion, not just agree with everything.
That also brings me to an interesting point. You probably don't want to have one doctor. You probably want to have a healthcare team. And the reason for that is this, that first of all, the time of the doc in a box, what we used to call, or like this idea of a rural one doctor takes care of a whole village kind of thing, that fantasy is all gone long time ago, more than 2 decades ago. Somewhere in early 2000s, such a model just completely disappeared. And it's simply with our current complexity of healthcare that is infinitely increasing. It's exponentially getting more complex. Too much information, specialization, interest of providers, the fact that your system in place may not support certain broader things. It's just all kinds of reasons. It's not just one reason. You basically want to say to yourself the following: what do I need as a patient? What are my weaknesses that I will need to support for a long time? And here's how I think. You need a gatekeeper. So you need a person who knows a little bit about everything, who can be your mirror. who can reflect to you what is happening, who can reflect to you and say, hey, I hear you, but let's try this. That's one. But you also need providers within your weak link. Let me give you an example. You mentioned methylation. A lot of good primary care doctors will have no idea what you just said, right? And it's not their fault. And you may say, look, that's fine. You don't know this. I'll just find a nutritionist who I'm going to meet on an annual basis, who understands all this. They will
write tests and write things. Yeah.
Or even better, where that nutritionist can work with your primary care doctor. And then the nutritionist will send a message to your doctor, say, hey, Dr. So-and-so, can we get this test? And then I will take care of the managing that. So that's what you want. You want this kind of a collegial working relationship. But let me give an interesting, different example. Let's say you have scoliosis your whole life. And because of that, you have a mild chronic back pain. And because of that, your pressure on your skeletal system is a little different. And because of that, if you do certain activities, you have more pain, you're more likely to fall, you're more likely to have a certain specific trauma. And so suddenly I may say, you know what? The most important two people for you, more important than me, are going to be an Alexander technique master.
For balance and
also to optimize, and also some kind of a manual therapist, whether it's a physical therapist, a gifted massage therapist, it doesn't matter. Like I personally feel anybody who's physically very active must have some kind of regular body work. And so it may just be easier if your insurance will pay them. Yeah. And even if the insurance doesn't pay for it and you're going to still go for it, well, pay them annual fee so you don't have to worry about, and you always have access to them.
My last question here was, it's not really a question, I called it a reaction. With you, it's too easy because it looks like you want to work with people who are proactive.
That's exactly right.
But do you have any recommendations? How do you find a doctor who actually on that side? Because I've seen in my experience, again, doctors who just want to be authoritative figures who don't want to listen to anything. They have procedures you have to follow, or
there's a kind of a Google search option, basically, and the keywords there would be integrative medicine, lifestyle medicine. Definitely functional medicine. And also I would use, if you're state licensed naturopathic doctors, I would also use that as a search. And then you have to also decide the cost, right? So there's a lot of pragmatic things that go here. Like, if you have a very good insurance and you don't want to spend your dollars for whatever reason, that's fine. I mean, then you would need to see who is in the network there, right?
Yeah, because I have to have primary care. So
we don't have primary care system in US. Your insurance tells you to get a primary care doctor, but the reality is it's just because the insurance says so, because they need to have a referral for every visit you make to a specialist. So you have to have somebody on file. But what you can do with this situation, when you have a limiting, not very good insurance, here's how I always tell to my patients: get the maximum flex account or HSA account, health saving account. Maximize amount of dollars you can put in there.
Absolutely.
Get your primary care. You may see that doctor every 5 years, whatever, if you're completely healthy, just so that if something does happen, you have a system in place. But then find the practitioners who's going to support your health, right? Not your emergencies. Because if you're in your 30s or 40s, I mean, emergencies can happen. You're very active. You go skiing, you fall down, you break a leg. Okay, fine. You want to have insurance for that. Like, one thing I will actually say for your listeners and for my listeners, do have insurance. I mean, it's not appropriate, and it's actually, I would say, crazy in this day and age not to have insurance. And think that nothing's just simply because of one factor. If with this situation you will end up in a hospital for whatever the reason is, I don't know, there's all kinds of reasons. The bear attacks you in the middle of the forest, right? You will be paying for this for the rest of your life. I often say you don't have to sometimes get the best possible insurance, because you're going to be paying a lot of money per month And quite often,
it's better to spend those money on a doctor, on a test.
That's it, is to spend out-of-pocket money, but put that money aside and target your health instead of target like some pain, and then just anticipating a hospital admission being 100% covered no matter what. Because if you're relatively healthy, you're probably never going to, or you may not never need it. But then setting aside a budget so that you know how those dollars are spent, and they're spent on your health, not on your illness. This is the critical aspect. When you enter a standard healthcare system, 90% of entering that happens because you have some problem. You have to learn to enter healthcare system because you don't want that problem, because you want to stay healthy. And right now, there's no system in place. US does not have system in place. The prevention and entering for preventive services, the way it's organized has nothing to do with actual prevention. It's really early screening for 90%. You can have a great doctor. Like, sounds like the guy who just recovered was a great doc who was working with you. You can be lucky and if you find a person like that, hold on to them for your dear life, because, they're also not common. Rare breed, exactly. Yeah. I would say it's even more rare breed for them to take insurance. But on the positive thing, I think we're all going to start using AI. We're all going to start using coaches. I think a lot of coaching will shift to AI. In fact, I think most of the coaching will be AI based, and it will be a lot more efficient than currently. It's probably also going to cost a tiny fraction of the current costs. In fact, here's the idea. If one of your listeners is a coach, I would be very careful, and I would start looking for some other job, because I think most of the coaching jobs in the next 10 years are going to get outsourced.
Or you get on top and use those tools, AI tools,
That's
actively, so you know how to prompt them and be more efficient with your time. So it looks like, at least to summarize, for my situation and probably for a lot of people, it makes sense to have a primary care who is open-minded and can send you to the right specialist, and possibly have a second doctor, like a functional doctor, who might be out of insurance, but we still see him once a year or twice a year to do some extra work, extra tests. Of course, all of them has to be selected carefully, probably with all the questions I've asked.
And know your weaknesses, and create the system for those weaknesses. That is not necessarily engaging physicians, that engages other provider that may just be better suited. I mentioned physical therapists, for example. In fact, in my practice and for myself and for my family, I actually, we have primary care on file, but I haven't seen that person in 7 years. But I have a physical therapist who I see at least twice a year. Why? Well, because I have certain musculoskeletal challenges. I'm very physically active. I exercise a lot.
You want to get aligned.
Yeah, I need to get aligned, and also because sometimes stuff happens. I will fall down, or and then so I will go and see Jessica and say, this happened, and then because you also don't want that to accumulate. You don't want those micro traumas to become like growing concern, and suddenly you have all kinds of musculoskeletal prevention. Instead of being proactive, instead of being reactive, act to your healthcare challenges early as you can possibly do so, and then put some kind of a live to 150, follow Alex program, because that's actually, I think, why not? We have all kinds of tools now, and I think the science is marched.
There is no downside, at least from my point of view.
Exactly.
Because if you align yourself with that thinking, you're more likely to make the right choices, and if you make the right choices, you suddenly live longer.
That's right.
It's a win-win.
Yeah, I call this approach age-wise. I have a book published by Oxford University Press coming out sometime in the spring next year.
Oh.
Now, there's a lot of books on aging already, but I think my point here as a geriatrician goes like this. A lot of the anti-aging out there is completely impractical. Like, you did this wonderful comparison. There's this guy, what's his name? Is it Johnson? You know who I'm talking about, the guy who does like hundreds, if not thousands of tests.
Yes. Brian Johnson. And you did this wonderful video where you're like, but if you just do this couple of things, it's probably going to be just as good. So that's the way I think. I think in those terms, what are the sort of the core package that you have to do? Yeah, it's like a Pareto principle. Can you do
Right. But then I also
moves the needle.
Exactly. But then on top of that, I add what are the things that you should anticipate, and more importantly, when you already have certain challenges, because most of us, let's face it, right?
Yeah, we'll do. Of course.
We don't have $2 million and a team and per year and then follow all this. The reality is we're all coming to it with some package. So there's going to be some help. So the book is all about when you already have these medical problems, how do you integrate those problems with the healthy approach overall as a prevention. So, yeah.
I would add that you still need, even if you have a great doctor, you still have to educate yourself.
You must.
Absolutely must.
You are the best doctor. And one of my favorite clinicians of all times, Melinda Ring at Northwestern in Chicago, she did a TED talk on this. That's basically, you will always be the best doctor for yourself. And do not ever try to find a doctor to replace yourself, so to speak. You have to know your health better than anybody else. And that's often a mistake that people think. They're going to think, oh, my doctor knows me. Oh, I have this. I'm going to go and they're going to... No. You have to be responsible for your health first. You have to understand your challenges. You have to know how to handle them. You have to know who you need to access to optimize things. Do not rely on anybody else. Not because if you're super rich and you can create like a complete team, even then, because in reality, those people will never know you as well as you know.
Yeah, you still need to be in charge.
You have to be.
We like to say that educated people live longer, but it's not just because they have more income. It's because they make educated choices.
Decisions. That's exactly.
Educated decisions. Yeah. And especially if you're in the States or any Western country, you need to be in charge of your own education. That's just how the system works. I actually just made a video about Dunning-Kruger curve and how to move.
Yeah, I saw it was really cool.
So that's... anyone watching?
Yeah, and if you listening to this and you're like, oh, they didn't talk about this, we're humans, right? We make mistakes. Put the comments, we'll come back together. You see that we're in sync, we like talking. We'll do another one soon. Hope everybody's having a good day.
Right, thank you so much.